thanks again, though, for inviting me. I am very fond of minimally invasive spinal surgery, but I also want to say that the goal is not to do minimally invasive spine surgery. The goal is to do the right operation for the right patient and to avoid complications, right? That said, though, I think that what MIS allows us to do frequently is actually avoid complications of open surgery, and I'll talk about that a little bit. This is a cartoon that we put together for this recent publication that some of the faculty, they are actually co-authors, and this busy cartoon tries to summarize all or most of the things that we do in MIS surgery. And you can see just by looking at this busy slide that there are lots of opportunities for complications. And I'll try to address some of these, certainly the ones that I think are probably the more concerning ones and that maybe happen more frequently. And I think where there is opportunity and there are strategies in place to address them early on or totally avoid them or fix them. Keep in mind that MIS tries to achieve the same or better outcome than traditional open surgery while minimizing iatrogenic damage to soft tissues and while obviously trying to avoid complications. So that's the goal. So it is important to talk about complications. And in this book and in several talks, we kind of put together some of the aspects of surgical development that all of us go through and that are important in addressing and going through properly, sometimes with training, with teaching, with mentors, to avoid complications and to be successful in any type of spine surgery, but especially in MIS, because it is sometimes technically a little bit more demanding. The most important thing, I think, is really number one, which is patient selection, target, the right patient, the right operation. Techniques, we'll talk about that a little bit. So the surgical techniques, that's difficult to teach, really. That's something you do in your residency, your fellowship, sometimes in cadaver labs, surgical simulation. The fun stuff is obviously tools and technologies. There's so many tools that we use, and you could see that on that slide before. And again, opportunities to misuse them or have complications. And then teaching and training is very important. Now, let's talk a little bit about patient selection, target, surgical decision-making. And this is really the number one opportunity to avoid complications. You got to get an accurate diagnosis. So the whole idea of MIS is to focus in on the patient, and I'm talking primarily about degenerative spinal issues here, but also others, of course, but especially for degenerative, where patients present with focal neurological deficits, maybe radicular pain, cervical, lumbar radicular pain, that potentially can have a million different etiologies. It is important to really figure out very carefully where's this pain really coming from, and that requires a very thorough evaluation of the imaging studies. The neuroradiologist personally is my best friend. I review a lot of imaging studies with really good neuroradiologists because it can be so important to avoid unnecessary surgeries or avoid operating on unnecessary levels, which again translates in less invasive surgery and less complications, hopefully. So you got to review the history, get a good physical examination, review the imaging, and then try to correlate as much as you can the symptoms with all the other factors that I mentioned. It's very helpful to work in the multidisciplinary team with spine, non-operative spine practitioners. So we have a spine center where we have pain management, physiatry, neurology. You may want to get an EMG. You may want to get focal blocks to really figure out where is this pain coming from. And then in many patients, you can cut down the extent of your operation, avoid unnecessary surgery, and hopefully have a much more targeted and better outcome. The other thing you got to understand is the natural history of the disease. If you know that somebody has an unstable spondylolisthesis, it's probably a good idea to take that into consideration and do a fusion at the same time. But if it's a stable spondylolisthesis, that may not be necessary. Just an example of how natural history make a, and we don't understand a lot of the natural history. That's a problem also. But you got to at least try to consider that and try to put the best evidence together to figure out how does the natural history of a particular disease process affect your surgical decision making. And then finally, the impact of your surgery. And this is really where MIS comes in. if somebody has a spondylolisthesis in the lumbar spine, for example, if you do an open traditional surgery, it's much more likely to have instability post-op than if you do an endoscopic or tubular over-the-top decompression. So that's how the choice of your operation really affects your outcome and your complications post-op. If you put all these and more together, hopefully you'll come up with the best surgical solution. Unfortunately, we should have a whole course about this because this is so important. Now, this is an example of a patient where, in my opinion, the patient selection was off. This is a patient who had the least invasive spinal fusion done that I have ever seen. This patient came from Europe. She had surgery done a year before I saw her, and had essentially presented with the same pain that she had before surgery, neurogenic claudication, no mechanical back pain. These were the x-rays, so they put cages in percutaneously, they put bone cement for some reason, and she fused. She had a great fusion, but she had the same symptoms that she had pre-op, neurogenic claudication. So the MRI scan showed that she still had stenosis here, and now she had adjacent level stenosis as well. So they missed the boat here. They did a beautiful MIS operation, but target was totally off. Patient selection was totally off. Some of you have seen these pain charts in clinic. Don't do it. This is you can't win unless you really cut this down to a particular symptom or disease process. You're not going to be able to help these patients for the most part. So that, I think that's great advice if you want to avoid unnecessary surgery and complications. So we'll talk about many of these points here on the slide. So we'll talk about CSF leaks, screw misplacement, KY complications, infection rates, and so forth. It's a pretty depressing talk. So, however, studies have shown early on, even there's a paper that we put together with some of our residents more than 10 years ago, that if you compare open versus MIS TLIF surgery, at least based on the publications, complication rates are potentially lower than with open surgery. And this is already 13 years old. So something is happening even back then already with MIS that potentially cuts down on complication rates. And I think what that is primarily is probably infection. I mean, that's probably the one thing that we've seen over and over again in all types of publications, endoscopic surgery, tubular surgery, MIS TLIFs, that infection rates are lower than with traditional open surgery. And probably that is because instead of having a lot of soft tissue exposed for considerable amounts of time, with endoscopic surgery, obviously you have the irrigation of water all the time. There's no tissue exposed really. And with tubular surgery, you have very, very little tissue exposed. And I think that's probably one of the main reasons why infection rates are so low with MIS. The concern, however, is spinal fluid leaks. And I remember last time I gave this talk here, there was a little bit of a heated discussion afterwards. So I'll try it again this time. So this is a patient that I saw a long time ago where I got a CT scan. I was worried about that synovial cyst. Indeed, it was very calcified. I published a paper maybe 10 years ago where I described doing these from a contralateral approach through a tube. So just the decompression coming in from a contralateral approach. My rationale at the time was that you come from a more normal anatomy, and then you see the cyst, and that's on this little photograph here below, where you come from the contralateral side, and then you dissect the dura away from the cyst under the microscope, and then you can remove the cyst from the contralateral side. So now I don't do that anymore. I actually come ipsilateral, because if you get a leak, if you get a CSF leak from a contralateral approach on the other side through a tube, you can fix it, but it makes it very, very difficult. And so I've learned my lesson. I retract the paper that I wrote 10 years ago, and I come actually in from the ipsilateral side now for these synovial cysts, also when they're calcified. And there are ways to fix CSF leaks through tubes. Many of you are familiar with that. I'll show you what I do typically. But again, a lot of it is, again, patient selection, right? So somebody like this patient here who had previous surgery, and you can see there's a lot of scar tissue here. So if you have to go back and do a fusion for whatever reason or any other operation, it would be great to avoid, obviously, the area where the scar tissue is, where there's a higher leak of the leak. There's a case where I didn't do that. There's a different case, but there's a patient maybe a year ago or so where somebody took a picture intra-op from the microscope. This is a patient with previous surgery. I went back, I did a TLIF in this patient, and ended up with this leak. However, even these leaks, I fixed this through a tube with direct closure, and you can fix those, but obviously it's something that you rather want to avoid. Sometimes you see post-op these CSF leaks. I use the Scanlon dural repair set, which is an endoscopic, they call it an endoscopic repair set. It's not really endoscopic, but it's bayoneted, as you can see here. And then I use this needle, this Neurolon needle. It's like a fishhook needle that you can use to really pull up the dural edges from almost like from underneath. And then there's a knot pusher, and that seems to work very well. It's a 4 Neurolon braided suture that I use for CSF leaks. The other thing that I do, if I have to go back, I sometimes use plastic surgery. Not if it was a tubular, but if it was open surgery, certainly when I go back and to fix a CSF leak, I have a low threshold to get the plastic surgeons involved, also to avoid infection rates or to lower infection rates in revision surgeries. And I think that's something that's more and more common now, that surgeons really utilize their plastic surgery colleagues to avoid revision infection rates, but also to address sometimes spinal fluid leaks. Obviously, if you go through a tube, if you go back through a tube, there's nothing the plastic surgeon can do. But if you really have a hard time closing a leak and you make the incision bigger, then the plastic surgeon can allow you to put the muscle flaps down and get rid of the dead space. But what I've learned, though, is that in this case, who had this patient that I've showed earlier, where there was scar tissue, and I thought that I had to go back to do a fusion for some other reason. I try to modify the approach, so I try to avoid direct decompression. And what we've done recently is obviously lateral surgery, OLIF surgery. You totally avoid the side of the CSF leak. But if you want to go from the back, I've been utilizing ELIF, which is an extraforaminal discectomy and fusion, which essentially is just a modified TLIF approach, but it's great because you totally avoid the dura. And that in this particular case, this patient had a decompression. We had to go back to a fusion. So we went, instead of doing a TLIF here, we went extraforaminal. So we did an extraforaminal approach, lateral to the facet joint, minimal invasive, of course. And that has been described. There are not many larger series, but it is a really nice approach that I've been utilizing recently more and more. And I do everything with navigation. I use total navigation, no fluoroscopy, nobody wears lead. So I put in the screws first. And then on the side of the ELIF approach, I don't put screws in first, but I drill the holes. I mark the holes with the navigation, so I have the holes already prepared for later. But then I go back and put the screws in at the end. So this was one of those ELIF cases where I put the screws on the contralateral side. This is the reference array for the navigation. And then on the contralateral side, I drilled already the holes for the screws, but then because I go more lateral, I put the tubular retractor where usually the screws would be. And this is with navigation. This is the trajectory that you see then through the tubular retractor. This is the entry point for your discectomy. So you're lateral to the facet joint, and these screw holes here, I've already drilled them and I've marked them here in different colors so I can find them afterwards very easily once I take the tube out. So then I do the discectomy, and then you see the exiting. This is coming in from the left side at 4-5, I think, and you can see the exiting nerve root here. So obviously you're trading one complication against the other. So you don't see the dura, but you got to be really careful with this exiting nerve root and with the DRG, that you don't manipulate that too much. So that's the complication that you're trying to avoid when you do this operation. And you got to be careful, obviously. But the results are great, and I think it's a great alternative to traditional TLIF surgery if you want to avoid the dura. Still a concern, obviously, with any spinal fusion, but especially with MIS, is non-union and loosening of screws. I showed you earlier publication from 13 years ago where the fusion rate with MIS TLIF was 95%. However, not sure if you can really trust those numbers. People publish, obviously, sometimes fusion rates without really having adequate follow-up imaging. And it is certainly a big concern with MIs because you're so heavily relying on the interbody fusion in the disc space, there's no real room to do a posterolateral fusion. That's the whole point of doing it MIS. So you got to spend a lot of time with your discectomy. I spent sometimes 20 minutes doing the discectomy. I rarely use BMP. Sometimes in high-risk patients, I use BMP. But when I use it, I use one small sponge and I put it all the way in the front of the disc space. Then I put autograft bone. I always use autograft bone from the facet. I use expandable cages. Then I backfill the expandable cages with bone graft. So the BMP is far away from the dura. But I use BMP maybe in 10% of cases. Again, patients where I'm really worried about the fusion. So the fusion rates and now this is the paper that I mentioned before. So even 13 years ago, if you looked at the published results, the fusion rate with MIS TLIF was 95%. However, about 50% of these authors used BMP, and I think that it is not necessary to use BMP in every patient if you prepare the end plates, use autograft bone, and really spend a lot of time with a discectomy. And I use sometimes iliac crest bone from the iliac crest in these patients, but I always use autograft bone from the facet joint. And this, an intraoperative CT scan that I get at the end of the case, you see the cage here and then all the bone graft that surrounds it. So I think it's really important to do that. Another innovation for MIS TLIF surgery is expandable TLIF cages. And I like expandable cages, but you got to be very, very careful with subsidence. And there's an example where we did an adjacent level TLIF here, and we overexpanded the cage, and it goes into the end plate below. And then if you use BMP, then you're potentially in trouble, because with that, with the end plates being fractured and BMP, there's a high risk of causing even more problems. So you got to be very, very careful with expandable cages. There's a learning curve. We're looking at that right now. So you expand it just a tiny little bit, enough so you get tactile feedback. I think that's really important. But you can get really nice results with expandable cages. And this, we're just looking at our series of about 120 cases done over the last few years. The first half of those cases I did with an expandable titanium cage that just expands in height. And now for the last year and a half, 2 years, I've been using a different cage that expands in height, but also recreates lordosis. So if you use these cages very carefully, and if you compare the segmental lumbar lordosis that you can get at the levels of the surgery, you can really get some adequate and some moderate but nice lordosis with these expandable cages that also increase in lordosis. But you got to be very, very careful with subsidence. Screw accuracy, obviously, that's like the worst case scenario. This can happen with navigation, without navigation, can happen to anybody, of course. So it's really, the point is that you have, whatever technology you use to put in your screws, you got to be very, very careful. I'm not a big fan of robotic surgery. I think you get more tactile feedback with navigation, but I'll talk about that in a few minutes. I used to use K-wires maybe 10, 15 years ago, until I had a bunch of imaging studies that looked like this, where the K-wire broke off, and then we had to go back here with a laparoscopic surgeon to fish out the K-wire. So I really tried to get away from K-wires, and there are companies now that make these single-step pedicle screws, MIS pedicle screw systems that you can navigate, that work really nicely. And we've been using these maybe for 5 or 6 years now, very, very successfully. And they really allow you to get into, and I use it with 3D navigation. If you have an anatomy like this, for example, I think with a robot, I'd be very, very worried, because you don't get, in my opinion, I don't use it, but my concern would be that you don't really get any tactile feedback. With freehand 3D navigation, you dissect down with your finger, you can feel the anatomy, and then you can get really nice tactile feedback, even when you put in your pedicle screw. And in this case, because the pedicle was so small and corticated, we used a navigated all-tip and then put in the screw later. So I'm a big fan of navigation, but I really make sure that I always get tactile feedback. And I think it's also good for the residents and fellows so they can correlate what they feel with their fingers and what they see on the screen. And we publish our results with these MIS pedicle screws. Now, the last thing I want to talk about is really teaching and training, because I think that that is obviously so important. And I've had the great privilege to work with the AO for many years, of course, and we put together within the AO, as an attempt to create a curriculum for MIS, we put together a group of experts from all over the world, orthopedic, neurosurgical experts, and we put together a curriculum that now summarizes most of the endoscopic and tubular procedures for degenerative disease, MIS, TLIF included, endoscopic decompressions, and it is in the AO Surgery Reference app, which you can download for free. We all use it for the trauma classifications, of course, but now it also has a section for MIS surgery, for degenerative MIS surgery, and it walks you through all the steps for an MIS over-the-top decompression, for example. So I think that's very valuable, and the more you can utilize that, obviously, the better prepared you are when you go to the OR, and hopefully the better will the outcome be. So one study that we did through the AO was utilizing these educational materials from the task force. So we had 12 surgeons work on a real spine model to do an over-the-top decompression 3 times in a row using this educational material. And what we saw with surgical simulation with these real spine models was that the time of the surgery decreased from the first to the third surgery in these 12 surgeons. And then also the number of mistakes that the surgeons did decrease. The number of incorrect starting holes for the drilling, pars injury, CSF leaks, all these complications decreased over time. So that was really nice evidence in surgical simulation that you can actually teach and train these procedures, not only in the operating room, but also with surgical simulation. And that's, again, something where the courses that you're doing right now comes in so handy. You get cadaver experience, but surgical simulation, I think, is going to be very, very important as well. So I'm not going to talk about axial lift. That's too depressing. But I want to summarize the kind of my key points. And again, my key point, I think, is really the patient selection. I think that's the most important thing in avoiding complications in any type of surgery, especially spine surgery and especially MIS. And then obviously techniques, which you can learn at the course where you're at now in the cadaver lab, tools and technology. Be aware technology is important, but things can go wrong. And then teaching and training. And I think that the AO and other organizations have done a great job, but there's much more that we should do to really prepare residents and fellows, not only on patients, but also in surgical simulation settings and in the labs. So thanks everybody. Thanks for your attention.
Thanks very much, Dr. Hartl. Does anybody in the audience have any questions for Jens?
Wait, I have to, microphone's not on. Is the microphone on? Yeah, here it is. Hey, Roger, the only reason why you're excused to not be here in person is because you're flying to our mutual hometown, Munich, Germany, so I recognize that. And have a Weissbier and a pretzel for me when you're there. So we all want to learn how to be better, and this infamous word of learning curve applying to patients translates into complications and unacceptable outcomes. Clearly, you and your colleagues like Richard Schuras also and so many others have done a fantastic job in widening our skill set in armamentarium. To lessen the learning curve, obviously, rigid didactic agenda are necessary. Now, here's my point. The plastic models that I've seen and that we've tried to train with really leave me highly dissatisfied. There's more and more elaborate stuff in there. There's CSF flow now. You've put arteries in there and everything, but boy, I mean, it's nowhere close. So how can we really learn the skills outside of understanding the dogmatic and the didactic accuracies that you've brought into place, so the checklists? So what's the best way to learn and practice without practicing a learning curve on a patient?
Yeah, Jens, that's a good point. I agree that there's no perfect way of doing that. There are advantages and disadvantages. The plastic models, and there are a number of companies out there, and it varies in terms of the part of the anatomy that they're trying to simulate. there's some, in terms of the bony anatomy, the drilling part, which is so important for MIS and for any type of spine surgery. So I'm pretty impressed. I think that they do really a great job. And if it's about, for example, teaching somebody how to operate through a tube or through the endoscope, how to do the drilling, how to understand the anatomy, I think for that part, these models are really helpful. Obviously, there are other parts of the surgical procedure where maybe these models are not perfect, but I think it is an improvement over what we've had in the past. Certain things you have got to do with cadavers, probably. Certain things you can do with surgical simulation. There's no perfect model out there, but I think we're much further ahead now than we were maybe a few years ago.
One of the challenges sometimes with MIS is that very factor when you have a resident that you're trying to teach or a fellow that you're trying to teach. It's an MIS surgery. Sometimes it's more difficult to have the fellow or resident participate in the surgery without them being the main surgeon doing the decompression. How do you navigate that situation? Like, say, for instance, in an open case, if you're doing the decompression, it's an open case, and I do my side, the fellow or the resident does their side. Whereas if it's through a tube, it's mainly one operator.
Yeah, it's a big problem. I realized that recently when we had a discussion with surgeons who used to do MIS TLIF and then went back to go and do an open TLIF for exactly that reason, because they realized that if you do an MIS TLIF, you got to do everything yourself. As you get older, now that becomes a problem. Or if you have like overlapping rooms, which a lot of institutions still have, right? So I don't know. I mean, I don't have the answer to that, but I realize that as you get older, as an MIS surgeon, you got to do everything yourself, because also then you get better. So you have other expectations from your fellows that they can't even, they can't get there because they haven't done enough cases. It is a problem, but I think that's where surgical simulation and teaching and training, I think, really comes in. And as much as I understand what Jens said, I disagree, though, to a certain extent, because there are components of this operation that we can teach very, very well with surgical simulation over these plastic models, and the drilling is part of that. So, but I realized that one of the potential downsides of MIS, and that may become a big problem in the future, is that you create surgeons who are used to working on their own, and it becomes potentially a problem.
Yeah, Jens, I think you wanted to say something.
I want to acknowledge something that you said and highlighted. I'm a almost full-time revision surgery these days. That comes with gray and balding hairlines. So I see a lot of badly done surgeries, obviously, and all hubris aside, I see a consistent pattern that you emphasize, and I want to highlight that: disc prep. So people seem to be happy to stuff some device, whatever it is, into a disc space and call it good. And there's no fusion. And again, as you said, the disc space is your fusion zone. And if you don't do an adequate disc prep, it's not going to work. So again, you said 20 minutes or so disc prep. Some tips, tricks, how can we kind of hardwire that there should be an adequate bone graft and an adequate release to make a fusion actually happen, besides stuffing some hardware into the disc space?
Yeah, and I use I don't know. I mean, there's like a detail maybe, but I use first of all I use a microscope, so I kind of focus into the disc space. But now there are little endoscopes that you can put into the disc space also. I think Zeiss has one of those, but it's too short. It doesn't. I tried. It's too short to get into the disc space. But there are visualization devices. I use 90-degree down angled curettes with two hands to really scrape the disc space, and I have 3 different sizes, and I find that for me works the best. But I spend a lot of time, and I just want to mention that Jens, you maybe 15 years ago at a course, I was talking about over the top decompression, coming with a tube from one side to the other. You stood up and you said, how can you explain to a patient if you have a complication on the left side, but you went in from the right side, or vice versa? And at the time I belittled that, but I got to tell you, I think about that statement every time I do this operation, And I and I try to explain it to the patient beforehand that we're going to go from one side, but we're operating on both.
Cool. Thank you so much. I appreciate it, Dr. Hartle. Great to hear your talk.
Thank you.